Hello everyone, I am Mohammed Hamama, and this is your ASCP preparation camp. In this camp, we will go through each topic on the ASCP lecture list. In today's video, we will be discussing bone marrow failure. Bone marrow failure is the reduction or cessation of blood cell production affecting one or more cell lines. Pancytopenia, or decreased numbers of circulating red blood cells, white blood cells, and platelets, is seen in most cases of bone marrow failure, particularly in severe or advanced stages. There are multiple mechanisms involved in the pathophysiology of bone marrow failure, including the destruction of hematopoietic stem cells due to injury by drugs, chemicals, radiation, viruses, or autoimmune mechanisms. Premature senescence and apoptosis of hematopoietic stem cells due to genetic mutations. Ineffective hematopoiesis due to stem cell mutations or vitamin B12 or folate deficiency. Disruption of the bone marrow microenvironment that supports hematopoiesis. Decreased production of hematopoietic growth factors or related hormones. The loss of normal hematopoietic tissue due to infiltration of the marrow space with abnormal cells. The clinical consequences of bone marrow failure vary depending on the extent and duration of the cytopenias. Severe pancytopenia can be rapidly fatal if untreated. Some patients may initially be asymptomatic, and their cytopenia may be detected during a routine blood examination. Thrombocytopenia can result in bleeding and increased bruising. Decreased red blood cells and hemoglobin can result in fatigue, pallor, and cardiovascular complications. Sustained neutropenia increases the risk of life-threatening bacterial or fungal infections. Bone marrow failure resulting from other mechanisms may present similarly to aplastic anemia, and differentiation is discussed later. Accurate diagnosis is essential to ensure appropriate treatment, as there are many mechanisms involved in the various bone marrow failure syndromes. Aplastic anemia is a syndrome in which the bone marrow fails, and it is a rare condition that can be fatal. The patient had severe anemia, neutropenia, and marrow that lacked cellular components on post-mortem examination. The primary characteristics of this condition include low counts of all blood cells, reduced levels of immature red blood cells, a deficiency of hematopoietic stem cells, and decreased cellular components in the bone marrow. Acquired aplastic anemia accounts for about 80 to 85% of all cases, while inherited cases make up the remaining. Acquired aplastic anemia can be classified into two major categories: idiopathic acquired aplastic anemia, which is not associated with any known cause and make up 70% of all aplastic anemia cases, while secondary acquired aplastic anemia is linked to a specific cause and make up 10 to 15%. Both types have similar clinical and laboratory findings, with patients presenting with macrocytic or normocytic anemia and reticulocytopenia. Pancytopenia may develop slowly or rapidly, leading to the complete cessation of hematopoiesis. The cause of idiopathic aplastic anemia is unknown, while secondary aplastic anemia is associated with exposure to certain drugs, chemicals, radiation, or infections. Cytotoxic drugs, radiation, and benzenes are responsible for 10% of secondary aplastic anemia cases and suppress the bone marrow in a predictable, dose-dependent manner. Generally, the bone marrow recovers after the withdrawal of the agent. Approximately 70% of cases of secondary aplastic anemia occur due to idiosyncratic reactions to drugs or chemicals. Idiosyncratic secondary aplastic anemia is rare, and genetic and environmental factors in susceptible individuals may contribute to it. Currently, there are no readily available tests that predict individual susceptibility to these idiosyncratic reactions. However, genetic variations in immune response pathways or metabolic enzymes may play a role. Acquired aplastic anemia can occur as a complication of infection with the Epstein-Barr virus, HIV, hepatitis virus, and human parvovirus B19. Aplastic anemia associated with pregnancy is rare. About 10% of individuals with acquired aplastic anemia have a concomitant autoimmune disease, and approximately 10% develop hemolytic or thrombotic manifestations of paroxysmal nocturnal hemoglobinuria. Pathophysiology. Acquired aplastic anemia is caused by a deficiency of hematopoietic stem cells. Patients with this condition have diminished colony formation and reduced CD34 cell population in the bone marrow. CD34 cells have increased expression of apoptosis-related genes and FOS receptors. Although bone marrow stromal cells are healthy and able to generate high levels of erythropoietin, thrombopoietin, granulocyte colony-stimulating factor, and granulocyte macrophage colony-stimulating factor, FLT3 ligand, but the use of growth factors typically do not effectively treat the cytopenias associated with acquired aplastic anemia. Autoimmune cytotoxic T lymphocytic destruction of stem and progenitor cells in acquired aplastic anemia occurs due to exposure to drugs, chemicals, viruses, or other agents that cause. Evidence supporting autoimmune pathophysiology includes elevated blood and bone marrow cytotoxic T lymphocytes, increased T cell production of cytokines like interferon G and tumor necrosis factor alpha, upregulation of transcription factor Tbet, increased tumor necrosis factor alpha receptors on CD34 cells, and improvement in cytopenias after immunosuppressive therapy. Some individuals with aplastic anemia have single nucleotide polymorphisms in cytokine genes, resulting in cytokine overproduction and genetic susceptibility to aplastic anemia and contributing to its severity. CD4, CD25, and FOXP3 regulatory T cells are decreased in aplastic anemia, which normally suppresses autoreactive T cells, and a deficit of these cells may facilitate an autoimmune reaction. Correct differentiation between acquired and inherited aplastic anemia has important implications for appropriate treatment and prognosis. Immunosuppressive therapy is not nearly as effective in inherited aplastic anemia as it is in acquired aplastic anemia. Clinical findings. Acquired aplastic anemia has a range of symptoms from asymptomatic to severe. Patients with aplastic anemia typically show symptoms of insidious onset anemia such as pallor, fatigue, and weakness. Severe and prolonged anemia can lead to cardiovascular complications including tachycardia, hypotension, cardiac failure, and death. Symptoms of thrombocytopenia are varied and include petechiae, bruising, epistaxis, mucosal bleeding, menorrhagia, retinal hemorrhages, intestinal bleeding, and intracranial hemorrhage. At initial presentation, fever, and bacterial or fungal infections are unusual but may occur after prolonged periods of neutropenia. Splenomegaly and hepatomegaly are typically absent in acquired aplastic anemia. Laboratory findings. Pancytopenia is common in aplastic anemia, but initially only 1 or 2 cell lines may be decreased. Absolute neutrophil count is decreased, while the absolute lymphocyte count may be normal or decreased. Hemoglobin is usually less than 10 grams per deciliter, MCV is increased or normal, and reticulocytes counts are decreased. Neutrophils, monocytes, and platelets are decreased in peripheral blood, and red blood cells are macrocytic or normocytic. The serum iron level and percent transferrin saturation are increased, which reflects decreased iron use for erythropoiesis. Liver function test results may be abnormal in cases of hepatitis-associated aplastic anemia. Paroxysmal nocturnal hemoglobinuria (PNH) clones are present in about 2/3 of patients with small numbers, and PNH diagnosis is important due to the increased risk of hemolytic and/or thrombotic complications. Bone marrow aspirate and biopsy specimens show prominent fat cells with areas of patchy marrow cellularity, and severe hypocellularity is a characteristic feature. Inherited aplastic anemia. Compared to acquired aplastic anemia, individuals with inherited aplastic anemia typically develop symptoms at a younger age and may exhibit physical features that are specific to their condition. The three inherited disorders that commonly result in bone marrow failure and pancytopenia are Fanconi anemia, Dyserythropoietic congenita, and Shwachman-Boedian-Diamond syndrome. Fanconi anemia. Fanconi anemia is a disorder characterized by chromosome instability, cancer susceptibility, and aplastic anemia, along with physical abnormalities. Fanconi anemia is the most common among the inherited aplastic anemias. Clinical findings. Patients with Fanconi anemia have variable features and symptoms. Physical malformations may be present at birth, but hematologic abnormalities may not appear until older childhood or adulthood. Only 2/3 of patients have physical malformations, which can vary considerably. There is a higher frequency of skeletal abnormalities, skin pigmentation, short stature, and abnormalities of the eyes, kidneys, and genitals. Low birth weight and developmental delay are also common. Symptoms associated with pancytopenia usually become apparent at 5 to 10 years of age, although some patients may not present until adulthood. Individuals with Fanconi anemia have an increased cancer risk, including an increased incidence of leukemia in childhood and solid tumors in adulthood. In approximately 5% of cases, a malignancy is diagnosed before the Fanconi anemia is recognized. Dyserythropoietic congenita. Dyserythropoietic congenita is an uncommon genetic disorder that results in bone marrow failure, and there are only approximately 600 recorded cases of the disease across the globe. Clinical findings. Dyserythropoietic congenita is characterized by mucocutaneous abnormalities, bone marrow failure, and pancytopenia. The typical clinical presentation involves a triad of abnormal skin pigmentation, dystrophic nails, and oral leukoplakia. Skin and nail findings usually appear before 10 years of age. Median age of diagnosis is 15 years. By 30 years of age, 80% to 90% of patients have bone marrow abnormalities. Patients can manifest a wide range of multisystem abnormalities, including pulmonary fibrosis, liver disease, developmental delay, short stature, microcephaly, prematurely gray hair or hair loss, immunodeficiency, dental caries, and periodontal disease. Patients have a 40% risk of cancer by 50 years of age, most commonly acute myeloid leukemia, myelodysplastic syndromes, and epithelial malignancies. Shwachman-Boedian-Diamond syndrome. SBDS is a rare genetic disorder that affects multiple systems in the body. It is characterized by pancreatic insufficiency, cytopenia, skeletal abnormalities, and an increased risk for developing blood cancers. Clinical findings. Shwachman-Boedian-Diamond syndrome is characterized by peripheral blood cytopenia and reduced pancreatic enzyme secretion, which results in gastrointestinal malabsorption that usually manifests in infancy. Patients also exhibit immune dysfunction and neutropenia, which makes them susceptible to severe infections and sepsis. Nearly all SBDS patients have delayed bone maturation, and around 50% of them experience failure to thrive and short stature. Laboratory findings. Nearly all patients with SBDS have neutropenia. Half of the patients also develop anemia or thrombocytopenia, and 1/4 develop pancytopenia. The RBCs are usually normocytic but can be macrocytic, and approximately 2/3 of patients have elevated hemoglobin F. The bone marrow is usually hypocellular but can be normal or even hypercellular. Due to pancreatic insufficiency, 72-hour fecal fat testing shows increased fat excretion, and serum trypsinogen and isoamylase levels are decreased compared with age-related reference intervals. Patients with SBDS have normal sweat chloride tests, distinguishing it from cystic fibrosis, which can have a similar malabsorption presentation. Testing for the SBDS gene mutation is commercially available and should be done in suspected patients and their parents. Please don't forget to subscribe to our channel, activate notifications to get our new videos. If you like our content, please press the like button, and share the video with your friends. If you have any questions, leave a comment below. Other forms of bone marrow failure include pure red cell aplasia, congenital dyserythropoietic anemia, myelophthisic anemia, and anemia of chronic kidney disease. Pure red cell aplasia. PRCA is an uncommon condition affecting erythropoiesis, which is marked by a selective and severe reduction in erythrocyte precursors in an otherwise normal bone marrow. Patients with PRCA experience severe anemia, typically normocytic in nature, as well as reticulocytopenia. They also have normal white blood cell and platelet counts. PRCA can occur either congenitally or acquired, and distinguishing between the two is crucial as the treatment approaches vary. Acquired pure red cell aplasia. Acquired pure red cell aplasia is a rare disorder of erythropoiesis characterized by a selective and severe decrease in erythrocyte precursors in an otherwise normal bone marrow. It may occur in children or adults and can be acute or chronic. Primary PRCA may be idiopathic or autoimmune related, while secondary PRCA may occur in association with an underlying thymoma, hematologic malignancy, solid tumor, infection, chronic hemolytic anemia, collagen vascular disease, or exposure to drugs or chemicals. Therapy is first directed at the treatment of the underlying condition, but immunosuppressive therapy may be considered if the PRCA is not responsive. Cyclosporin is associated with a higher response rate, 65% to 87%, than corticosteroids, 30% to 62%, and is better suited for long-term maintenance if needed. The acquired form of PRCA in young children is also known as transient erythroblastopenia of childhood. A history of viral infection is found in half of patients, which is thought to trigger an immune mechanism that targets red cell production. The anemia is typically normocytic, and hemoglobin F and erythrocyte adenosine deaminase levels usually are normal. Red cell transfusion support is the mainstay of therapy if the child is symptomatic from anemia. Normalization of erythropoiesis occurs within weeks in the vast majority of patients. There may be a genetic predisposition to transient erythroblastopenia of childhood in some families. Congenital pure red cell aplasia, Diamond-Blackfan anemia. Diamond-Blackfan anemia, DBA, is a congenital disorder characterized by erythroid hypoplasia in early infancy, with an estimated incidence of 7 to 10 cases per million live births. Mutations have been identified in 9 genes that encode structural ribosome proteins, disrupting ribosome biogenesis in DBA. However, the pathophysiological mechanisms leading to clinical manifestations are currently unknown. Nearly 50% of DBA cases are linked to an autosomal dominant inheritance pattern, but sporadic mutations have also been reported. Over 90% of patients show signs of the disorder during the first year of life, with a median age of 8 weeks. However, some patients with DBA are asymptomatic until adulthood. Approximately half of patients have characteristic physical anomalies, including craniofacial dysmorphisms, short stature, and neck and thumb malformations. The characteristic peripheral blood finding is a severe macrocytic anemia with reticulocytopenia. The WBC count is normal or slightly decreased, and the platelet count is normal or slightly increased. Bone marrow examination distinguishes DBA from the hypocellular marrow in aplastic anemia, as there is normal cellularity of myeloid cells and megakaryocytes and hypoplasia of erythroid cells. The karyotype in DBA is normal. In most cases, HbF and erythrocyte adenosine deaminase are increased. These findings distinguish DBA from transient erythroblastopenia of childhood, in which these levels are normal. Congenital dyserythropoietic anemia. Congenital dyserythropoietic anemia, CDA, is a group of rare disorders characterized by refractory anemia, reticulocytopenia, hypercellular bone marrow with markedly ineffective erythropoiesis, and distinctive dysplastic changes in bone marrow erythroblasts. CDA does not progress to aplastic anemia or hematologic malignancies and can vary in severity from mild to moderate. There are three major types of CDA, CDA1, CDA2, and CDA3, and some rare variants that have been assigned to four other groups, CDA4 through CDA7. CDA1 is characterized by a mild to severe chronic anemia and is caused by mutations in the CDAN1 gene on chromosome 15, which encodes codenine 1, a cell cycle-regulated nuclear protein. CDA2 is the most common subtype and is caused by mutations in the SEC23B gene on chromosome 20. It is characterized by mild to moderate anemia, with RBCs being normocytic with anisocytosis, poikilocytosis, and basophilic stippling. CDA3 is the least common subtype, associated with mutations in the KIF23 gene, and is characterized by mild anemia. Treatment options for CDA include interferon A and iron chelation, splenectomy, and supportive care. Myelophthisic anemia. Myelophthisic anemia is caused by abnormal cells infiltrating and replacing normal hematopoietic cells in the bone marrow. Tumor cells, particularly from lung, breast, and prostate, leukemic cells, fibroblasts, and inflammatory cells, found in miliary tuberculosis and fungal infections, have been implicated. Cytokines and growth factors released by these cells suppress hematopoiesis and destroy stem, progenitor, and stromal cells, resulting in cytopenia. Immature hematopoietic cells are released into the circulation due to the disruption of normal bone marrow architecture by infiltrating cells. Stem and progenitor cells migrate to the spleen and liver and establish extramedullary hematopoietic sites. Anemia severity is mild to moderate, with normocytic erythrocytes and reticulocytopenia. Teardrop erythrocytes, nucleated RBCs, immature myeloid cells, and megakaryocyte fragments are observed in peripheral blood. Abnormal cells can be detected in a bone marrow aspirate or biopsy specimen. Anemia of chronic kidney disease. Anemia is a common complication of chronic kidney disease, CKD. The primary cause of anemia in CKD is inadequate production of erythropoietin by the kidneys, which stimulates red blood cell production in the bone marrow. Other contributors to anemia in CKD include uremia, chronic blood loss, iron deficiency, chronic inflammation, and a restricted diet. Anemia in CKD can lead to cardiovascular complications, kidney failure, and reduced quality of life. Annual hemoglobin testing is recommended for patients with CKD, with investigation if the hemoglobin is less than 13.5 grams per deciliter in adult men and less than 12 grams per deciliter in adult women. Treatment includes erythropoiesis-stimulating agents, ESAs, with a target hemoglobin range of 11 to 12 grams per deciliter, along with monitoring of iron stores. Hyporesponsiveness to ESA therapy can occur due to functional iron deficiency, FID, which can be diagnosed through certain blood tests. Other causes of ESA hyporesponsiveness include chronic inflammatory disease, infection, malignancy, and certain blood disorders. Thank you for completing the video. Remember to ask for ASCP short notes, and don't forget to subscribe. Bye.